Assalamualaikum and salam sejahtera. I'm going to share my slide now. Right, I shall be talking about vestibular migraine. It is a difficult topic to cover, a lot of uncertainty about this entity. What I'm going to do in this lecture is to firstly give a brief overview of headache in general and migraine specifically, and then speak about the epidemiology, clinical features, diagnosis, and treatment of vestibular migraine. The first thing to say is that a lot of people, when they have chronic headache, even chronic intermittent headache, they're worried about a brain tumor. But the fact is that brain tumors rarely present only with headache. If you only have headache, it is unlikely, right? Because unless the tumor is big enough to invade these pain-sensitive structures, namely the skull, right, the periosteum, meninges, and all blood vessels, then there shouldn't be any pain from the head. So when the tumors are big enough, they more commonly present with the other features first, like the ones in the third bullet here. So they would present most commonly with epileptic seizures before headaches, change in personality. I knew a psychiatrist who died in UKM from just a change of personality without any headache from a brain cancer. And of course, with focal neurological signs like visual field defects, hemiparesis, ataxia, and also a rapid cognitive decline, then you would suspect a brain tumor in that situation rather than with a headache. That's the first thing I want to say. So in case any of you in the audience have this, don't worry about a brain tumor. I'm going just to focus on primary headache. There's so many causes of secondary headache, which of course I have no time to talk about, and it's not the focus of this lecture. Basically, the simple way to think about it is that there are three basic primary headaches. There are many more, but the most common ones are these, probably the most important ones: migraine, tension headache, and cluster headache. And when someone migraine eventually develops tension headache as well, we call it sequential headache. Vice versa is less common. That means starting with tension headache and then developing migraine. That's less common. But this is not a sequential headache. And then when patients have both, they tend to abuse painkillers, notably Panadol, codeine, the opioids, and also ergotamine. Then they get what we nowadays call medication overuse headache. And the treatment there is not to give more painkillers, but to withdraw the painkillers and to rescue with a migraine-specific medications, which I'll come to later in the talk. So how common is migraine? It is, as you know, more common in women. It depends which country you take the data from, but overall, it's about 12%. In women, it's up to 25% of women have migraine. In men, it's up to 15%, but more like 10%. So this is a commonly underdiagnosed entity, right? Some patients have migraine attacks once in 2 years, and then you say it's kepala sakit biasa. Sakit kepala biasa actually is a non entity. It doesn't exist. And I'll talk about this again later in my talk. So who suffer from migraine? So most commonly in adolescents and young adults. As you grow older, people tend to grow out of their migraine attacks. So this is the sort of age distribution of migraine. Is migraine a disease of city dwellers? I was once called by Astro to give a radio talk show, and I said yes, because in UKM, we did a study, not me actually, my predecessors, on the Orang Asli, or Orang Asal, they call it nowadays, in Kuala Lipis. No one suffered from migraine, no one suffered from headache. They don't know what headache is. But when they moved or they were put into settlements, smaller settlements like Gombak and also Bukit Lanjan, some people develop migraine, but the prevalence is low. But once they integrate into society in the city, then migraine became a common thing as well. So migraine really is related to work schedules. We have deadlines. Orang asli don't have that, deadlines and schedules. You don't have to plug 200 buah kelapa in one day. There's no such thing. Driving is another thing, focusing on the road with your neck like this, working at the desk with a computer. These are risk factors to develop migraine, as proven in some studies. Therefore, there's no migraine in orang asli. They don't have to worry about these things. So migraine is an invention of modern city living. How about genetics? Genetics is more common in migraine sufferers than non-migraine, than tension headache, and much more common in common migraine or migraine without aura. Sorry, this is a busy slide, but just to show you, they have discovered certain genes related to migraine and located in either chromosome 1, 2, or 12. So these genes have been discovered and may contribute to hereditary predisposition to migraine. These are the criteria in the International Headache Society for migraine. So you have to at least fulfill, at least 5 attacks must fulfill the criteria from B to D. The duration of each attack is between 4 to 72 hours, so up to 3 days. Anything less, like minutes or seconds, is not migraine, or anything too long is also not migraine, whether successfully or unsuccessfully treated with medication. And headache has at least 2 of the following features, 2 out of these 4. So unilateral location or onset, pulsating quality. We prefer the word pulsating than throbbing. Different people mean differently with the word throbbing, just like berdenyut. Berdenyut in Malay may not be actually pulsating. Some people use the word berdenyut to mean intense pain, so describing intensity rather than the quality. The pain should be of moderate or severe intensity, so you're looking at a pain score of like 6 and above, aggravated by or causing avoidance of routine physical activity, example, walking or climbing. So you don't need to be stressed physically to have a migraine, although unaccustomed exercise, like you've never played squash before, now you start playing squash, you can get a migraine attack. That happened to me once. During the headache, you must have at least one of the following: nausea and or vomiting, right? Or photophobia and phonophobia. So either one. And lastly, not better accounted for by another international classification of headache disorders, edition 3, diagnosis. So if it doesn't, it cannot be explained by tension headache or cluster headache, then it is migraine. You need just this criteria clinically. You don't need to do a scan or blood test to diagnose migraine. Now, let's look at the migraine aura. This only occurs in about 10% of patients, so it's not common. It's more common to have migraine without aura, or what we call common migraine. This is called classic migraine. And the duration of the aura is between 5 and 60 minutes. And the headache should occur within 60 minutes of the aura, right? And you can see here that vertigo is one of the auras in migraine. So patients with migraine with aura can have vertigo. But these are some of the symptoms. The typical aura is a visual disturbance. Most commonly it's called as fortification spectra, where they see zigzag lines across the visual fields. It's like looking at a road which is tar road, right, black, and then on a hot sunny day, and you see this like evaporation of moisture coming out from the surface of the road. That's what they look like. Okay, so that's fortification spectra. I won't talk about the others because it's not a talk about migraine. And migraine versus tension headache, but just concentrate on migraine, it should be throbbing, unilateral, I've mentioned before. But look at the triggering factors. Of course, I'm going to come back to this again later. Too little sleep, sleep deprivation, or too much sleep can also trigger migraine. Skipping meals, right? Hypoglycemia. Overexertion, I mentioned before. You play squash, you've never done it before, just to show your mother-in-law, you might get a migraine attack. Change in stress level, even too much relaxation. I get that. I have migraine attacks, and I get that during weekends. So I call it weekend migraines, and that's been described and published. Excess of afferent stimuli, such as bright lights, as you know, can happen. Weather change, cold to hot, hot to cold, And of course, if you take drugs like GTN, because the vasodilator, alcohol can also induce migraine and menstruation as well. Of note, about food, not all chocolates, cheese, wine, and so on can cause migraine. It has to be individualized. For me, it is belacan and durians. They contain amines, they may vasodilate. That's why you feel very heaty, warm when you eat lots of durian. Right. Let's talk about vestibular migraine. It is very under-recognized and underdiagnosed. I don't think I've diagnosed vestibular migraine in my life, but it is of unknown pathophysiology, right? So treatment is going to be difficult, not knowing the pathophysiology, but I'll show you some publications on this. Normal or inconsistent tests of vestibular function. Typical migraine headaches may not occur, although it's called vestibular migraine, and only recently recognized as a distinct entity. It's probably among the most common causes of recurrent spontaneous vertigo, right? In middle-aged women, it may account for 5% of recurrent spontaneous vertigo. So it's quite common. It's slightly more common in females. The ratio varies from anything from 1.5 to 5:1. And the median age of onset is from the mid-30s or mid-40s, with a range of 8 to 50 years. And the mean duration between headache onset and vestibular symptoms is about 8 years. So there's a delay, a latency before you start developing these vestibular symptoms. And it is more pronounced, maybe more pronounced around menopause. And in some families, there's an autosomal dominant inheritance, especially in men. And however, there's lack of evidence for a monogenic inheritance, so it's probably polygenic. So I'm just going to go through this International Classification of Headache Disorders, ICHD-3, which was published 3 years ago, 2018. And just to show you that vestibular migraines is only listed under Appendix 1.66. So it's a minor, like a small print. So it is not, although it's a recognized entity, it is still not fully understood. So it's really down the list in the ICHD-3 classification. If you look at causes of vertigo in the general population, vestibular migraine probably comes in number 4 here, accounting for about almost 12% of cases presenting with with vertigo, right? So it's fairly common but poorly understood. And of course, this data, you have to take it with a grain of salt, depending on what criteria you use to diagnose vestibular migraine. Now, this is the ICHD-3 diagnostic criteria for vestibular migraine. So again, at least 5 episodes fulfilling criteria C to D, right? Firstly, it says here you must have a current or past history of migraine, with or without aura. So you must have that, that's a must. And then C, vestibular symptoms of moderate or severe intensity, lasting between 5 minutes to 3 days. The 3 days like any migraine attack, interfering or preventing activities of daily living. That's moderate or severe. At least half of the episodes are associated with at least one of the following 3 migrainous features, which some of these, all of these I've mentioned earlier in the migraine talk, right? Where the headache should be unilateral location, pulsating quality, moderate severe intensity, aggravated by routine physical activity, photophobia and phonophobia, and then visual aura. So you must have at least one of these in half of the episodes. And again, not better accounted for by another ICHD-3 diagnosis or by another vestibular disorder. So it's kind of a diagnosis exclusion, and you just need this clinical criteria. So importantly, headache and vestibular symptoms do not have to temporarily coincide. They don't have to occur at the same time. They can be years before this migraine. Now, no more migraine. You only have vestibular symptoms. So it's difficult, yeah? You might have it's important to know the differential diagnosis here. And then the ICH, right? Identical question of headache, they subdivided this into probable vestibular migraine, where It's listed here, yes, 3 things. At least 5 episodes with vestibular symptoms of moderate or severe intensity lasting 5 minutes to 72 hours. We've mentioned that before. Well, now you only need one of the criteria B and D for vestibular migraine to be fulfilled. So migraine history or migraine features during the episode, right? And again, not accounted for by another vestibular or ICHD diagnosis. These are some of the previously used terms: migraine-associated vertigo or dizziness. This is what I used to use when I was a young neurologist. Migraine-related vestibulopathy and migrainous vertigo. I've used that as well. So I may have underdiagnosed vestibular migraine earlier in my career. So what are the vestibular symptoms? These are the common symptoms. Spontaneous vertigo may occur up to 85% of cases, depending on which paper you read. Whereas positional vertigo is slightly less common, but it's still common. It may occur up to 60% of cases. Some patients may have visually induced vertigo, usually induced by complex or large moving visual stimuli. And head motion vertigo, again, common up to 80%. Head motion induced sensation or disturbed spatial orientation with nausea, and misperceptions such as feeling of imbalance or tilt, which you all should know as ORL specialists, and vomiting and susceptibility to motion sickness. So these are some of the features, vestibular symptoms that occur with migraine. I mean, I have migraine. I get nausea. Sometimes I have dizziness, but I don't regard myself as having vestibular migraine, because these things may happen even with migraine sufferers, as you saw earlier. And some of the terms used by patients, right? The one I showed just now were medical terms, but they would say I have spinning, rocking, tilting, swaying, unsteady, off balance, off kilter, lightheaded, foggy, clouded, or disorientated, drunk or sick, seasick, floating sensation, walking on air or pillow, coming off a roller coaster or merry-go-round. So these are some of the descriptions given by patients. To continue with the vestibular symptoms, it is regarded as moderate vestibular symptoms if it interferes but does not prevent activities of daily living, or severe if it prevents daily activities. Duration can be seconds to days, yeah. Least common with if they're seconds only, and usually is related to head motion, visual stimulation, changes of head position. The one that occurs in days may even occur up to 4 weeks to recover fully. You only need a minimum 1 symptom per episode to fulfill the criteria for vestibular migraine, and different symptoms may occur during different episodes. So it's not stereotyped with each attack. Associated symptoms may occur before, during, or after the vestibular symptoms. This is quite challenging. What about the headache? So the headache in vestibular migraine experienced by only 2/3 of patients. And the core migraine features in these patients should be similar to those of migraine with or without aura. And they should have similar migraine triggers. I've mentioned earlier, the visual stimulation, lack of sleep, too much sleep, it should be the same. Aura may occur in up to 1/3 of patients. Photophobia, phonophobia, I've mentioned earlier. So it's similar to the headache in VM, similar to the headache in migraine sufferers. In some patients, the headache and vestibular symptoms never occur together, as mentioned earlier. So that is, again, a big challenge for us. Some people may think that the vestibular symptoms is actually an aura of the migraine attack. As I mentioned earlier, it can be an aura, vertigo, right? But they rarely, right, these symptoms rarely immediately precede the headache. So it's not like behaving like an aura. And more than 60% of patients with migraine with brainstem aura report vertigo, right? So it's probably not that as well. It's totally different entity from migraine with brainstem aura, because both may present with vertigo. Less than 10% of patients with VM fulfill the criteria for migraine with brainstem aura. So again, to reinforce the fact that they're 2 different entities. Some patients may have both vestibular migraine and migraine with brainstem aura, right? Some together, so that you give a 2 diagnosis in the clinical notes. However, with the brainstem aura, you need at least 2 brainstem symptoms in addition to the visual, sensory, or dysphasic aura symptoms. What about Menial disease? Now, migraine and Menial disease may be inherited as a symptom cluster. And these patients complain of fluctuating hearing loss and tinnitus, which may occur in VM and migraine aura, and headache and photophobia may occur in Menial Disease. So it's a big overlap there. But together, it can be inherited. This is a big challenge for the diagnosis. Now, what about the differential diagnosis? I mentioned earlier, it's so important to have one, at least, so that you don't miss any dangerous things. So first one, of course, is migraine with brainstem aura. And any vestibular disorder superimposed with migraine attacks, of course, right? So migraine sufferers, I mentioned, can have vertigo, but migraine is more common in patients with benign proximal positional vertigo as well. Menial disease, I've spoken about, and persistent post-perceptual dizziness. Yeah, these patients have comorbid anxiety or depression, which is also seen in vestibular migraine, unknown pathogenesis. So how do we diagnose vestibular migraine? It is largely a clinical diagnosis. There is no pathognomonic clinical sign or laboratory test. I'm sorry, there's none. Vestibular laboratory tests mainly done to rule out differential diagnosis. And during an attack, however, you may get mild vestibular ocular abnormalities, such as abnormalities in eye pursuit. About half of the patients, spontaneous nystagmus can occur. Gaze-evoked nystagmus, slightly more common than spontaneous nystagmus, and horizontal head shaking induced nystagmus, which this, however, can also be seen in between attacks. What about the tests that we do for vestibular function? Conflicting results. Sometimes it points to a central cause, sometimes to peripheral vestibular dysfunction. Nothing is consistent here. Some patients have asymmetry in caloric responses. Some have abnormal, some normal ocular and cervical vestibular evoked myogenic potentials, but especially the ocular one can be abnormal. So this has been reported as well. Again, balance impairment, sometimes seen, sometimes not seen, abnormal Romberg tests, and increased swaying with the static posturography and sensory organization test, which you all know better than me. Mild and non-progressive hearing impairment can be seen in 8% of patients. Here again, you worry about Menial disease in some of these patients. The pathophysiology is poorly understood. I'm not going to show the complex, complicated diagram, just to simplify it this way. It involves, just like migraine, the trigeminal-vascular system. So there's neural and vascular factors. If you look at the system, it secretes CGRP, calcitonin gene-related peptide, and substance P, which will lead to vasodilatation and neurogenic inflammation. That will cause headache, right? But as you can see, the system also interacts with the vestibular system, leading to vestibular ocular dysfunction and vestibular hypersensitivity. And if you go upwards, it also connected to thalamocortical network, causing spatial disorientation and sensory dysmodulation. And it interacts with nociceptive brain stem centers. That's why you feel the pain, right? Because of these nociceptors in the brain stem. That's a brief description of the pathogenesis. Don't worry about that. Even we don't understand it very well. Now, these are some of the pointers to what could be the pathophysiology. In animals, in rats, trigeminal stimulation can produce nystagmus. So that's one thing to remember. In migraine patients, has been shown in humans as well, suggestive of increased vestibular excitability, right? So in patients with migraine, some of them, but not all. So it is, again, not consistent. The theory is that there's deficient habituation and potentiation of sensory responses in migraine pathogenesis. So there's altered perception of tilt during whole body configuration that suggests abnormal integration of semicircular canals and otolith inputs. And with lateral head tilts, there are large errors in spatial orientation in such patients. And there's large postural, patients with VM have larger postural sway with visual motion compared to control subjects. Structural and functional changes have been shown in the temporoparietal regions with MRI, and there's increased thalamic activation with cold water irrigation during functional MRI studies. So some of these things have been shown again, to try to explain the pathophysiology of VM. Coming lastly to the treatment of vestibular migraine, this is difficult because we don't understand the pathophysiology, but lifestyle modification may be the first thing you want to do. So you just avoid common migraine triggers. If you know that durians can cause this, avoid your durians, I'm afraid. If you know that coffee causes this, avoid coffee. Sleep deprivation almost is ubiquitous. It happens to all migraine sufferers, so avoid that, and of course, too much sleep. Adjust your diet, I mentioned earlier. Symptomatic relief with medication, I'll come to that again. Of course, you can refer for vestibular rehab therapy, and sometimes playing ping pong or dancing can enhance the perception of spatial orientation. So some of these things you can refer to the physical therapists or physiotherapists to institute to start this. Now, these are the drugs we use to prevent vestibular migraine. So these are some of the studies that have shown. I hope you can read this. Propranolol, also used for migraine with or without aura, has been shown to be effective. And then we have a list of antidepressants, venlafaxine in 2 studies, and then flunarizine, Cybelium it's called, the trade name, Valproate or Epilim has been used, and cinnarizine, of course, which you know, has been used to treat vertigo, so can be used in this patient. So this is preventive treatment, right? So basically beta blockers, antidepressants, calcium channel blockers, anti-epileptic drugs, and of course your cinnarizine. How about treatment of acute attacks? If you use triptans like you use for migraine, that has been shown to improve the attacks in such patients. So either sumatriptan, then you have zolmitriptan and rizatriptan. The last 2 have randomized controlled trials to show its efficacy, but they're not large. Antiemetics can be used, and one study showed steroid injections with IV methylprednisolone to be effective in aborting the acute vestibular migraine attack. Vestibular rehabilitation alleviates symptoms and promotes recovery. So some of these attacks can be referred acutely for rehab as well. So in conclusion, ladies and gentlemen, VM patients, vestibular migraine patients often experience disabling spatial misperceptions, including unusual sensitivity to head motion, visual stimuli, or sudden feelings of imbalance or tilt. So they can be quite disabling and stop them from doing their daily activities. The presence of episodic vestibular symptoms associated with at least one migraine feature fulfills the diagnosis of vestibular migraine. You just need one episodic vestibular symptom, and they may not occur together, the headache and the vestibular symptoms. The ocular and neurological examination should be normal, especially in between attacks. You shouldn't have any deficit. If you have to make sure there's no structural lesion that may actually directly kill the patient. Variable vestibular laboratory abnormalities have been shown because mainly due to lack of standard diagnostic criteria. And treatment is largely empirical and not solidly proven because of the lack of large RCTs for both abortive and preventive treatment. All right, thank you very much for your attention. That's all I have to say.